So these are great talks. I'm just going to kind of sum up here, but we'll just take a poll. So how many places are cloth hat or paper hats? The cloth hats. Any cloth hats still? You went back to cloth? That's data-driven. It just, that whole thing right there just shows you how things can get sideways, right? Okay, so I don't have any disclosures either. So the thing that I wanted to emphasize in the exercise that you'll do pulls these two concepts of quality and safety apart. So I wanted to explain how we're approaching that today. So quality can be considered, big Q quality, as the achievement of a positive outcome, whereas safety is the avoidance of a negative outcome. And these things get conflated together. But the arrow is meant to represent the day of an operation or an intervention. It could be starting a blood pressure medicine. It turns out on the day that we operate on people, you will never see the good thing, the reason why you took somebody to the OR. There's very few procedures, with the exception of trauma and things like handle pain control, where you see an immediate benefit to the patient. Usually, the day we operate, all you can see is the safety harm issues. So the reason to have a high reliability organization and limit your safety and harm is that if you do that, you get to see the good things sooner and for a greater amount of time. And so the magnitude of the quality is better. And we know that even one adverse event, like a massive PE after a liver operation, can completely wipe out for that patient and that physician any hope of seeing quality related to the intervention. But 95% of the metrics in our world are safety metrics, and very, very few things that we have in this space are actually quality, which is the good things we're trying to do for the patient. And there's a lot of theories going around. We were just talking about burnout, but one of the major impetuses or the reasons that we're experiencing burnout, why is it happening now, is actually the growth of safety metrics. So if you keep beating on people for their harm and you never talk about the good thing that they do, they will erode over time. And so this situation is actually tied up in burnout as well. So this gets to the informed consent discussion to kind of bring this home in a way. I do liver surgery, and I have never consented a patient where we say, okay, we're going to go to the OR, you have a tumor in the right liver, we're going to do a right hepatectomy, and my entire goal is that you not have a PE on day 2. Like, we never say that, right? You always approach the patient with what is the good thing. Like, we're going to take the tumor out and you're going to live longer. You're not going to need chemo, et cetera, et cetera, et cetera. And then we flip over and we give them a list of complications, right? So that's shared decision-making. If they get to talk about the quality side and the safety side, then we can get into shared decision-making. So there's lots of versions of the value formula. Because of these kind of issues, we wanted to pull apart quality and safety or harm. We started interpreting the value equation like this. So you take all the good things you could give to the patient, you subtract the harm, and now they can start comparing treatment A to treatment B, and if you throw in the cost data, you can do that. If you expand this out, it looks like this, and this is a very cancer-specific interpretation of this, but it really goes all ways. If you get down to the nitty-gritty of the quality things that we provide to patients, it's actually very few. There's survivals, functional recovery, and the experience they had while we did it. The only way to get at functional recovery is PROs. So you're never going to find it in your electronic health record. So, and in particular, in a lot of minimally invasive procedures that we do outside of the cancer space, we are actually doing things to cure symptoms. So if you think about anti-reflux operations, for example, lap chole, for example, you know, what you're aiming for is to make that patient more functional. In terms of the safety and harm, we talked about it. We are very good at beating each other up. We have kind of this ABCs of surgery, the assess, blame, and crucify culture. And so we do short-term complications of care very well, and the Joint Commission has brought us to score pain basically every 5 seconds for our patients, so we have that. What we don't account for a lot is the long-term disability that can come from our operations. And we got into a discussion in another forum about long-term disability, and several minimally invasive surgeons told me there is no long-term disability from laparoscopic surgery. And I said, oh yeah, what's your port site hernia rate? Because I guarantee there's a disability there. So there are long-term disability things that we need to talk about. And then on the cost side, you can look at this from the patient's or the institution side. So if we look at patient experience and move away from patient satisfaction a little bit, but to true patient experience, it's the degree with which we fulfill the goals of the patient. And so we can add up these goals. We've kind of covered this, and you'll get this on the paper we're going to hand out, but there are some known measurables of a quality measure. So how good is your quality measure? And a couple have been put up, but relevance, scientific soundness, feasibility, and comprehensiveness are some of the criteria we talk about. The next thing we're going to do is we're going to hand out this exercise. We're hoping to get people together at tables, maybe that share an interest in a particular type of surgery, or just group it up, and we'll pick a procedure. And we're going to kind of walk through a quality metric, a short-term safety metric, and a long-term disability metric, one after another. What I want to say is that the document is quite framed up on patient outcome, but you can also walk this back to process. So there might be something that you say, okay, well, that's the outcome. What process measure would directly speak to that? So if you want to move more in the process space, you can do that. If you want to stay with real functional outcomes, you can do that too. So I'm just going to talk through this, and then we'll hand it out and get started. So basically, you're going to pick a procedure. For example, you could say lap appy. So then you go to the next one. You're going to list the most common diagnoses that indicate that procedure: acute appendicitis, abdominal pain, etc. And then you have to describe the symptom burden. So what is the most common symptoms the patients with that diagnosis present with? And then which of those are disabling to the patient? So you can have a spectrum of symptoms that patients push right through and doesn't bother their activity or their function. You want to hit on the ones that actually bother their function. And then you decide which of those symptoms is fixed more than 50% of the time if you have a technically successful operation, right? You don't want to pick a quality metric on an operation that you don't fix commonly. And then we write a metric for that one, and you say what is a fail in that case. So that's the quality metric. For the safety metric, we're going to start with short term. List the 3 most common 30-day surgical complications for the procedure, and then grade them out. And so you can imagine if the most common thing gets 5 points, but it's fairly minor and it's kind of a grade 1, you multiply across, that's a 5. But if the second most common thing is, pancreatic fistula, and that's a 3 or a 4 on the harm scale, that might be a 15 or a 20. And whichever one gets the highest, you want to write a metric to that. And then finally, the long-term disability. What is the most common surgically induced disability present at 6 months after your operation? And then write a metric and define failure.